So maybe let's go back and focus on luspatercept a bit, because I think that's an interesting drug. We do have phase 2 data from the early studies at least showing that it's got responses of about 30% and maybe even 50% transfusion reduction, about 50%. So it's got some clinical activity. And at least my perception from clinical trial use and even commercial use off-label, pretty well-tolerated drug. Just want to get a sense what you guys feel about the addition of luspatercept. And where do you see it, if one was to use it, again, off-label, until the independent study reads out, where does it use best?
Yeah, I think based on the phase 2 data that we have available, using it in combination with ruxolitinib is where it makes the most sense, and it's definitely where I've used it the most. Although, and I have seen some really nice responses in hemoglobin and generally pretty well tolerated. But I have had some patients that are just anemic that have not done well on danazol or ESA, where I've used luspatercept by itself. But that's, again, smaller numbers and more anecdotal.
And it was effective,
And it was effective,
okay.
Yeah.
So with luspatercept, I think this is an agent that I think is interesting because I think from the phase 2 data, right, when you're talking about taking from someone from truly transfusion dependent to transfusion independent, that's a big jump, right? And so there's probably an additional percentage of patients, right? That was around 28%, 30%, right, was the response rate there. So there's probably an additional 15, 20% or so that are having benefit from the agent that maybe not measured by that kind of stark improvement in transfusion requirements. And so, I think when you go back, and I think the question is, what's the value of doing that, right? What's the value of making someone not need transfusions? Obviously, lifestyle, right? Like it's going to be nice for them not to be tied to the healthcare system, but you think about something like the RR6, right? Where you're talking about that person who's having growth of the spleen, right? Who's maybe requiring lower doses of ruxolitinib, who's requiring transfusion. Can you flip that risk model if you're able to make someone require less transfusions and allow them to be on a higher dose of ruxolitinib? I think that's something we haven't looked at there. But
yeah, we definitely don't have data to know if you are able to give luspatercept to improve the hemoglobin, can you really increase the dose of the ruxolitinib to, like you said, flip the RR6?